Hello, welcome to my channel. So today we're going to talk about nephrotic syndrome. So we're going to go through definitions, epidemiology, etiology, pathophysiology, clinical features, complications, and the approach to swallowing the child and the management. So let's start with the definition. So what is nephrotic syndrome? So this is just a manifestation of a glomerular disease, which is characterized by a nephrotic large proteinuria and a triad of clinical findings that are associated with large urinary losses of proteins. So in short, those things are hypobinemia, edema, and hyperlipidemia. So to give a summary of the definition, we said it's just a clinical syndrome of heavy proteinuria, then hypobinemia, and the edema, and the hypercholesteremia, or the hyperlipidemia in short. That's the definition of proteinuria. Okay, then for the heavy proteinuria, we can say it's more than 40 milligrams per squared meters per hour. We can say a urine protein creatinine ratio of more than 2.0 milligrams per millimoles, or more than 200 milligrams per millimoles. Okay. Then the hypobinemia, specifically, you can say a serum albumin of less than 25 gram per liter or 2.5 gram per deciliter. Okay. Then we go to the causes or the etiology. So the etiology we say, and before we talk about the causes, know that in terms of epidemiology, the nephrotic syndrome actually affects more boys than girls. There's a 2-to-1 ratio, and it usually occurs. It's usually prevalent in children between the ages of 1.5 to 6 years. That's the epidemiology. Okay. So continuing with the causes. So the causes, we say, we classify them as congenital nephrotic syndrome of the primary or idiopathic, and then we have the secondary etiology. So going to the congenital nephrotic syndrome. So the congenital nephrotic syndrome appears in the first 3 months of life, and most cases are due to genetic causes. So where we have mutations in the gene encoding nephrin and those encoding podocin. Then, of course, there are also some nephrotic syndrome in the first 3 months of life that may also be part of a multisystemic syndromes. For example, we have Pearson syndrome, which is just nephrotic syndrome plus eye issues. Then you can also have nail patella syndrome, which is just a nephrotic syndrome plus nail and patella deformities. Then you can also have a Dennis-Drash syndrome, which is the nephrotic syndrome plus nephroblastoma plus male pseudohermaphroditism. So that's Dennis-Drash syndrome. Then you can also have congenital infections such as syphilis and CMV. So those are some of the multisystemic syndromes that can even present with congenital nephrotic syndrome. Then after that, we go to the primary. So the primary or idiopathic, we have the most common cause, which is the minimal change disease. So minimal change disease more than 80%, and is called minimal change because if you look at it in a microscope, there's just minimal change. There's a little change to see in short. There's minimal change in short. That's where the name comes from. Then we can have in adults, you can say it's membranous nephropathy. That's the most common cause. So membranous nephropathy in adults. Then you can have membranoproliferative glomerulonephritis. You can have a mesangial proliferation. You can have focal segmental glomerulosclerosis. Those are some of the idiopathic or primary causes. Then you go to secondary. So secondary, we can have infections, so such as hepatitis B and C. You can have HIV-1. You can have syphilis. You can have toxoplasmosis, and we can have malaria. So those are some of the infections. Then you can also have a post-infectious glomerulonephritis. So maybe someone had a strep throat. Then after that, they may also, apart from developing the post-streptococcal glomerulonephritis. They can also even have a nephrotic range proteinuria as well, meaning they end up having nephrotic syndrome. Then the other is a systemic disease under secondary, where we have systemic lupus erythematosus. You can have Enoch-Schindler papilla. Then you can have diabetes mellitus. Then you can also have other secondary causes such as toxins and allergies. You have a bee sting, food allergies. Then you can also have another secondary cause, which is neoplastic, where you have lymphoma, leukemia. Then, of course, you can have traumatic or drug-induced, where you have penicillamines, NSAIDs, pamidronate, mercury, lithium, and gold. Okay, so those are some of the secondary causes. Then in terms of the pathophysiology, of course, there are a lot of theories on the pathophysiology, but just going to talk about the primary disorder, where we have loss of the glomerular basal membrane cyroprotein. So when there is a loss of the basal membrane, the glomerular basal membrane cyroprotein, there's going to, of course, loss of the normal negative charge, because remember the basal membrane is negatively charged, but when there's loss of that cyroprotein, there is going to be loss of the normal negative charge, which is going to increase the glomerular permeability, and massive protein. There will be massive proteinuria, meaning proteins that are albumin size, or even more than albumin size, can actually even pass through the membranes, in short. Okay, then after they start to pass through, there's going to be a decrease in serum protein, and the same decrease in serum protein is going to cause a decrease in plasma and cortical pressure, but especially with decrease in albumin. If there is that decrease, going to lead in plasma and cortical pressure will be decreased. Okay, then after it decreases, there's going to be a fluid shift from the vesicular to the interstitial, which is also going to lead to contraction of plasma volume. So that's typically the summary on pathophysiology. Then the other thing on pathophysiology we might actually want to consider is on the edema. So on the edema, there are two theories. We have the underfill theory and the overfill theory. So the underfill, as the name suggests, under meaning something is hypo. So specifically, we talk about the hypoalbuminemia. So when the hypoalbuminemia is one which is causing the edema, we say it's the hypo. We say it's the underfill theory. Then you go to the edema. If it's the overfill theory, we actually just talk about the tubular. We talk about the tubular sodium chloride reabsorption secondary to a renin-angiotensin aldosterone system, and intravascular expansion, which also leads to fluid shift following the pressure gradient. So that's the overfill theory. Then for the other pathophysiology on hypercholesterolemia, we say when there is hypoproteinuria, and the reduced number of proteins will also cause hepatic protein synthesis. So it will be a lot of proteins. It will be a lot of lipoproteins being synthesized by the liver, which will lead to an increase in the serum lipids, such as cholesterol and lipoproteins, and also an increase in lipid metabolism. So that's why there is hyperlipidemia or hypercholesterolemia. So that's the pathophysiology. We are done. Okay. And then the clinical features, we can have a sudden onset of dependent pitting edema, where we have periorbital edema, especially in the mornings. And then we can have scrotal vulvar edema as well. We can have ankle or leg edema. Then the other clinical feature, we can have weight gain, we can have ascites, we can also have diarrhea due to the intestinal edema. You can also have abdominal pain, anorexia. You can have respiratory distress due to pulmonary edema. And then, of course, in nephrotic syndrome, they are what we call the atypical features. So remember, atypical features, we can have decreased urine output, positive or minus, decreased urine output, positive or minus hypertension, positive or minus hematuria. So those are some of the atypical features. Okay, so we go to the complications. So under complications, we can have infections. So that's infections. So an example of infections, we can have spontaneous bacterial peritonitis, you can have cellulitis, you can have bacteremia. Specifically from examples, we can have a strep pneumonia, you can have staph pneumonia, then you can have E. coli, then you can have varicella as well. Then the other complication we can have is a steroid and immunosuppressant toxicity. Then you can also have hypovolemia. So that's one of the complications. Then you can also have thromboembolisms. So thromboembolism can lead to DVT, pulmonary embolism, stroke due to the hypercoagulable state, which is also due to decreased fibrinolytic factors. So there is urinary losses of anthrombin 3 and the proteins 3 and S. That's some of the things which can happen, and you can also have an increased synthesis of clotting factors which lead to thrombocytosis and an increased blood viscosity from the raised hematocrit. So that's why we say on thromboembolisms we can end up having DVT, pulmonary embolism, and stroke. Okay, so we've talked about most of the things, and the other thing is the other complication we can have is AKI. Then under the cardiovascular system, we can have hypertension, hyperlipidemia, coronary artery disease. And on the respiratory, so we had already mentioned pulmonary embolism. We can just repeat it again. On the respiratory, we can also have pulmonary effusion. So pulmonary effusion is also one of the respiratory complications. So we are done with the complications of nephrotic syndrome. So let's go to approach to a swollen child. So how would you go about the approach? So of course we start with history taking, where we ask if it's the first time relapse, if it's the first time or it's a relapse in short. Then also ask about the history of edema noted on. Is it on awakening in the morning or sudden swelling? And how is the distribution, color changes, any initiating factors like a big beasting, is it painful? Then you ask about weight gain. So is there edema? Then you ask about respiratory distress, is there breathlessness? Then ask about diarrhea, ask how the urine is. So in nephrotic syndrome, the urine is most likely to be frothy. And then you also ask about the past medical and drug history, bearing in mind because secondary causes, we mentioned drugs. So ask about any recent illnesses because, of course, secondary causes again. Ask about any allergies, ask about asthma. And then ask about the nutritional history, family history, those things. That's an on history taking. Then physical examination, have to assessment of the hydration status should be identified, which identifies the fluid imbalances. So in short, to assess for dehydration or over dehydration. Then of course you have to check the blood pressure. So specifically we want to see if the hypertension or not. That's a typical feature. Then you check for any papilla because it can be also any occasional and papilla. Then you check for any Mara rash, which is the butterfly rash. In systemic lupus, there is dermatosis. Then you also check for any crepitations which can be aid on line auscultation, which suggests extravascular fluid from overload or hypoalbuminemia. And then you can also have palpations. You can also have in the abdomen, which after palpation and percussion of the abdomen, it may reveal ascites or masses. Okay, then the liver enlargement might also be present in several multisystemic diseases, such as, again, systemic lupus erythematosus, infections, polycystic disease, and in glomerulosclerosis. So those are some of the investigations, physical examinations. Then differentials we can have for a child presenting with a swelling So if it's pedo edema, the thing we have talked about, so we can have nephrotic syndrome as a differential, since we just talked about approach to a swallowing child. But bear in mind that we're still talking about nephrotic syndrome. So we can have nephrotic syndrome, protein losing enteropathy, we can have hepatic failure, we can have heart failure, we can have acute or chronic glomerulonephritis, we can have protein energy malnutrition. So protein energy malnutrition as a differential for self-parenting with swelling. Okay. Then what are the investigations? So investigations we can do is a urine examination. We can have a full blood count and a blood picture. We can have renal parameters such as the protein, a spot urine protein creatinine ratio. We can also have a urinary protein excretion ratio. And then you can have a liver function test, a renal function test. So the analysis from the urine exam, from we can also do a analysis which might show us a nephrotic range proteinuria, which is just more than 2 plus, meaning 3 plus or to 4 plus proteinuria. Then we can have a renal function test, like we have mentioned. We have a spot urine protein, which is more, well, spot a urine protein creatinine ratio of more than 2.0. Then you can have a urine protein creatinine, a urine protein excretion. So this is just a urine protein excretion of more than 40 milligrams per square diameters per hours. Then you can have a serum creatinine, which is maybe normal or elevated. Then you can have a serum albumin, which is less than 25 grams per deciliter. You also have to check the serum cholesterol or the TGA, which is triglyceride levels, which also may be elevated. Okay, then other investigations we might do are complement levels, which means decrease, which suggests other than the minimal chain disease. Then you can have antitryptolysin or titer and the throat swab. You can have hepatitis B antigen, hepatitis C, RPR. Then you can have a renal biopsy. So since we have mentioned the renal biopsy, it's also important to talk about the indications for renal biopsy. So indications for renal biopsy can have age below 12 months. You can also have a low blood C3. You can have a gross or persistent microscopic hematuria. You can have hypertension. You can have impaired renal function. So others may even put AKI. Then you can also have failure of steroid therapy or steroid resistance, in short. Those are some of the indications for renal biopsy. Then what are some of the safety features for biopsy in adults? So even if they are falling under the indications, so there are some features we're supposed to look out for as the safety features. So FBC in adults should be more than 8 grams per deciliter, platelets more than 90, INR of less than 1.2. Then ultrasound, so an ultrasound you have to look at the kidneys. The kidneys should be normal, in short. So if they are small, then your biopsy will be contraindicated, in short. And then the BP would be less than 160/90. Those are some of the features before safety features before you do biopsy in adults. Okay, the management of nephrotic syndrome, we can have initial if it's an initial episode. The initial episode what we're going to do is high protein diet, salt moderation, treatment of infections. Then if there is significant edema, diuretics can be used, but cautiously. So remember, don't use diuretics unless you weigh the risks and the benefits. And even if you were to initiate it, you have to do it cautiously. Then, of course, the treatment is the corticosteroid therapy with prednisolone. So corticosteroid therapy for prednisolone, you can treat for 12 weeks. Then you divide into 3 times. So we have the 4 weeks, first 4 weeks, second 4 weeks, and the last 4 weeks. So the first 4 weeks, you give 2 milligrams per kg or 60 milligrams per squared meters per day, and we also give it once daily. So that's for 4 weeks. So that's the first 4 weeks. We give 2 milligrams per kg per day per oral. Okay, then we have the next 4 weeks, which we are going to give 1.5 milligrams per kg per, uh, per 1.5 milligrams per kg or 40 milligrams per cube meters per kg per oral, not per kg. This the 40 milligrams is per cube meters. Then now we are going to give it if it's on the 1.5 milligrams per kg or 40 milligrams per cube meters per squared meters. So we are going to give it on alternative days for 4 weeks. So that makes 8. Then the last 4 weeks, what we are going to do is we are going to taper steroids over the 4 weeks. So since the last 4 weeks we are giving 1.5, so we are going to taper maybe to go to 1.25, 1.0, 0 point something as we are tapering. So begin to taper down over the last 4 weeks until you reach a low dose, in short. That's the management for the first episode. Okay, then there are some important definitions so that's all about the management, most of the things. So the other thing maybe you can talk about is maybe the management for the edema. So of course the bed rest should be avoided as there is a resistance of hypercoagulability. Dietary advice also, you have to tell the patient not to add a lot of salt and the normal protein with adequate calories. Then you can also give prophylactic antibiotics like oral penicillins, particularly during the relapse with growth edema. And then you can also infuse for the hypovolemia. You can also infuse a salt poor albumin or 5% albumin, plasma protein derivatives or human plasma. Then of course we mentioned diuretics, and we also talked about why when you do diuretics. So those are some of the things we actually talk about. The management of some complications. If they present with infections, you can give parenteral penicillin, the third generation cephalosporin. So meaning that's management of some infections. Then if exposed to chickenpox and measles or varicella, you can give varicella zoster, you can give some immunoglobulins. Then they should be given within 72 hours after exposure to chickenpox or single dose of intravenous immunoglobulins, like I have said. Then for thrombosis, you can give warfarin, low dose aspirin, and some diprimadomo, or which all have been used to minimize the risks of clots. Those are some of the things you actually consider. Then of course there are some things which are important which we haven't talked about on the management. So there are some definitions for different for treatment of idiopathic nephrotic syndrome. So what are the definitions we are talking about? So definitions, we can have what the first definition is remission. So remission, we say this is urinary protein excretion less than 40 milligrams per squared meters per hour, or urine dipstick which shows nil or trace for 3 consecutive days. That's remission. Then we can have relapse, which is urine protein excretion more than 40 milligrams per squared meters per hour, or urine dipstick which is showing 2 plus or more for 3 consecutive days after remission. That's a relapse. Then you can have infrequent relapse. So infrequent relapse is when someone have 3 or less relapses per year, or we can have a frequent relapse where someone have 2 or more relapses within 6 months of initial response, or 4 or more relapses within any 2 months period. So those are some of the types of relapses that we talk about, the infrequent and the frequent. Then on the steroids, we can have steroid sensitive and steroid resistance and steroid dependence. So steroid sensitive, we define it as a normalization of proteinuria within 4 weeks after start of the standard initial therapy with daily oral prednisolone. And then steroid resistance, we can have a failure to achieve remission in spite of 4 weeks of standard prednisolone therapy. That's the resistance. Then steroid dependence, we define it as 2 consecutive relapses occurring during the period of steroid taper or within 2 weeks of its cessation. That's steroid dependency. Okay, then since we talked about steroid resistance, so how do you manage it? So we have symptomatic therapy under steroid resistance, where we just like we talked about the diuretics. If they are presenting with any edema, if they are presenting with hypertension, give them blood pressure control, such as S inhibitors or angiotensin 2 receptor antagonists. Then you also treat the hyperlipidemia. And then, of course, we go now to the immunosuppressive therapy, where we give steroids, or if those are still not working, you go to cyclophosphamide, cyclosporin, tacrolimus, and mycophenolate morphative. So these are just immunosuppressive therapy. We don't are not supposed to give them more, but you can use them for immunosuppression in short. Then we also talked about steroid toxicity. So there are some important things you are supposed to know about steroid toxicity, such as in the CNS, we have a benign intracranial hypertension. We can also have a neuropsychiatry conditions where we have dysphoria, depression, psychosis. Then on the eye, for steroid toxicity, we can have cataract, glaucoma, xanthomas. Then under the CVS, we can have hypertension, atherosclerosis, arrhythmias. Then under the respiratory, we can have pulmonary hypertension, we can have exacerbation of PTB. Then on the GUT, we can have hypokalemia, amenorrhea, infertility, IUGR. Then on the MSS, we can have air-related MSS, where we have alopecia or hirsutism. Then on the skin, we can have acne, striae, thin skin and easy bruising, poor wound healing, moon face, buffalo hump. Then on the muscle, we can have proximal myopathy. Then on the bone, we can have osteoporosis and also have vascular necrosis. Then under the endocrine, we can have central obesity, GM, hypothalamic pituitary adrenal insufficiency, then of course infections as a complication. So those are some of the features on steroid resistance, steroid toxicity. Then finally we end the management with education. So we have to educate the parents and school teachers also should be given information regarding this disease, so advice and precaution of infection, danger of sudden steroid withdrawal, immunization, those things. That's what we often talk about. So that's the end of the tutorial, and thank you for watching, and make sure you subscribe and hit the bell notification.